Welcome to today's deep dive. We're tackling something pretty complex but really fascinating in pediatric surgery today, cloacal malformations. Now, you might not have heard of this specific birth defect, but believe me, it's an incredible area of medicine. And the source material for this deep dive is really going to open your eyes to it.
Yeah, it's amazing.
We're looking at the 2024 edition of Cloacal Malformations Case Studies, edited by Dr. Mark A. Levitt.
Oh, a fantastic resource.
It's basically the guide for any healthcare professional who's, working with and treating this condition. It's packed with just tons of cutting-edge knowledge and those real-life case studies that help bring it all to life,
Yeah, absolutely.
So today, what we really want to do is we want to give you a clear understanding of what cloacal malformations are. How are they diagnosed? How are they treated? And what does that long-term care look like for these patients? Let's sort of rewind the clock a bit and look back at the history of this condition. It's interesting, we actually find references to cloacal malformations way back, way back in the Babylonian Talmud,
Wow.
which is roughly 2,000 years ago.
That's incredible. It really is fascinating to see how our understanding has changed over time. I mean, back then, they thought you could, just use a barley branch and like a simple procedure to fix it.
Wow.
We've come a long way.
Oh, clearly
We now know how complex this condition really is.
barley branches. I mean, wow, I can't even imagine. So, how did we go from barley branches to the surgical approaches we have today?
Well, it's been a long journey for sure. And there have been some major shifts in our thinking along the way. For centuries, the standard approach was what we call the abdominoperineal approach. Surgeons thought that the levator muscle was like the key to, fecal continence. But as time went on and they got more experience, they realized, well, it's not quite that simple. And that approach, the abdominoperineal approach, it often led to complications.
So what was the big turning point? What changed everything?
Yeah, the game changer was Dr. Alberto Peña and his groundbreaking work in the 1980s. He's the one who developed the posterior sagittal approach.
Right.
We call it PRSAR for short. It's a much more precise technique, and it really addresses those underlying anatomical complexities that we're dealing with here.
Right.
PRSARP has really become the gold standard today, and you can actually find a really detailed breakdown of this technique in Levitt's textbook. It's incredible.
That's amazing. And Dr. Levitt himself, the editor of the book we're looking at, he's been a major figure in pushing the field forward, hasn't he?
Absolutely. He's a leading expert,
Yeah.
He's taken Dr. Peña's work and he's, refined those surgical techniques even further. And he's also really helped us understand what that long-term care for these patients really involves. It's fantastic.
It's incredible to see how far we've come, right? Okay, so let's switch gears a bit now. Let's dive into how cloacal malformations are actually diagnosed. Where does that journey even begin?
Well, the first step is a really thorough physical examination right after the baby's born. It's crucial to really carefully examine the newborn, looking specifically for what we call a single perineal orifice. It basically means that instead of having those separate openings for the urinary, genital, intestinal tracts, there's just one opening.
Yeah.
And there's no separate anus either. That's another key sign.
So it's all about those very careful observations and noticing even subtle signs, right? I was reading in the book that there are these specific techniques they use during the exam that are super important. Can you talk about those a little?
Yeah, for sure. You're right. They may seem like small things, but they can make a huge difference in getting accurate diagnosis. For example, elevating the labia majora during the newborn exam, it can really open things up visually and allow for a much clearer view of all those orifices. Every little detail matters.
Yeah, I can see how missing something small could have pretty big consequences later on. It sounds like attention to detail is everything.
It really is.
Yeah.
And it goes beyond just the physical exam too. Imaging techniques are also a huge part of diagnosis, especially when we're talking about prenatal diagnosis. We can often identify potential problems before the baby's even born.
Oh, wow, that's fascinating. What kind of imaging tools are we talking about here?
Well, prenatal ultrasound is usually the first step. It can help us see things like hydronephrosis, which is swelling of the kidneys, or cystic structures in the abdomen. Those could be signs of a dilated vagina or bowel.
Okay.
And if we see those red flags, we know we need to do some more investigating.
So ultrasound is gives you those initial clues. What other imaging techniques are used?
There's this specialized X-ray called a cloagram. It helps us see the internal anatomy of the cloaca, which is that shared passageway where the urinary, genital, and intestinal tracts all kind of converge. It's kind of imagine a hallway where the plumbing for the bathroom and the kitchen is all mixed up together.
Oh, okay, yeah.
So the cloacogram lets us see how long this common channel is, and that tells us a lot about how complex the malformation is.
Right, so the longer the hallway, the harder it is to untangle everything, I guess.
Exactly. And then we also have fetal MRI. It can give us a more detailed look at things, especially the spine. We want to make sure there aren't any other anomalies going on.
So you're getting a really comprehensive picture of what's happening.
Yeah, that's the goal.
Okay, so let's say a cloacal malformation is diagnosed. What happens immediately after the baby is born? What are the top priorities?
Well, the first thing is always making sure the infant is stable, right? Making sure they're breathing okay, and addressing any immediate problems that need attention.
Of course. And I imagine there's also a need to check for any other potential complications that might be present too.
You got it. We do what's called a VACTRL workup.
VACTRL workup.
Okay. It stands for vertebral defects, anal atresia, cardiac defects, tracheoesophageal fistula, renal anomalies, and limb abnormalities. It's basically a head-to-toe check to see if there are any other associated anomalies that can sometimes go along with cloacal malformations.
So it's like a multi-pronged approach from the very beginning.
Absolutely. Along with stabilizing the baby and doing that vascular workup, another crucial step is addressing something called hydrocolpos.
Okay, hydrocolpos. I've heard that term before, but I'm not really sure what it means.
It's basically a buildup of fluid in the vagina. And it can be a pretty big problem. It can put pressure on the urinary tract, and in severe cases, it can even cause breathing difficulties.
Wow, that sounds serious. How do they usually treat hydrocolpos?
Usually, we drain the fluid using a catheter. Or sometimes we might create a small opening called a vaginostomy to let the fluid drain out. The main goal is to just relieve that pressure and prevent any further complications.
That's incredible. Okay, so we've stabilized the baby, we've addressed immediate concerns like hydrocolpos, ruled out other potential problems. What's next in the treatment plan?
Well, the next step is usually a colostomy. This creates like a temporary opening in the abdomen to divert fecal matter away from the urinary tract. It basically gives everything a chance to heal properly.
It sounds like the beginning of a pretty complex process.
Oh, it definitely is. But this is just the first step, It's a long journey towards reconstruction and restoring normal function. And that's what we're going to dive into next.
All right, so we've kind of set the stage, dealt with those urgent things right after birth. Now let's head into the OR, Let's talk about surgical reconstruction for these cloacal malformations. This is where things get really impressive with these surgeons.
Oh, absolutely. This is an area where we've made some truly remarkable strides. These are some intricate, delicate procedures, They require a deep understanding of the anatomy and just incredible precision.
Totally. So imagine this. Our tiny patient, they've had their colostomy, everything's stable. Now it's all about putting things back together, right? Like, can you walk us through those main surgical approaches for repairing these malformations?
Sure. So the two main techniques we use are total urogenital mobilization, which we often shorten to TUM, and then there's urogenital separation. Choosing between those two, it really comes down to the length of that common channel we talked about before. Remember that hallway analogy?
Right. The hallway where all the plumbing's mixed up. So how does the length of that hallway, how does that impact the decision between TUM and urogenital separation?
Well, think of it like untangling a knot, right? If the knot's small and the strings are long enough, you can kind of, gently loosen it and reposition everything without having to actually cut anything. That's kind of like TUM. When that common channel is relatively short and the urethra has enough length, we can carefully mobilize that whole urogenital complex, the bladder, the urethra, and the vagina, and get them all into their proper positions.
So TUM is it's like a realignment, making sure everything's where it should be. But what if the knot? What if it's more complicated? Like if that common channel is longer?
Well, that's when we go with urogenital separation. If that hallway is just too long, or if the urethra is too short to do a TUM, what we do is we very meticulously separate the vagina from the urinary tract, and then we reconstruct the urethra, usually using a portion of that common channel. It's a more intricate process for sure, but sometimes it's really the best way to make sure everything will function the way it should.
I bet. It sounds like both TUM and urogenital separation, they require such a high level of precision and skill from the surgeons.
Oh, absolutely. Yeah. And it's not just about separating and reconstructing either. We often have to address the vagina too. Sometimes it might be too short or even absent, so we have to reconstruct that as well. We try to use native tissue whenever possible, but sometimes we might have to use bowel segments or even skin grafts. It's pretty amazing, It's like rebuilding things from the ground up.
Wow, yeah. It's mind-blowing what these surgeons can do.
It really is. And it's a great example of how collaborative this field is. You have pediatric surgeons, urologists, gynecologists, nurses, all working together as a team. Everyone plays a crucial role.
It's a testament to teamwork and dedication, for sure. Okay, so surgery, that's a huge step, but it's not the end of the road, right?
Right. There's a whole other chapter focused on long-term care and monitoring. But before we get into that, I want to mention a tool that helps us predict long-term outcomes for these patients. It's called the Anorectal Malformations Index, or ARM index for short.
Okay, the ARM index, what is that exactly? And how does it help you, understand what the future holds for these patients?
Basically, it's a scoring system that looks at three main things. First, the type of anorectal malformation, then the status of the spine, and finally, we measure something called the lateral sacral ratio, which tells us about how well the pelvis has developed. All of these things play a role in predicting how well their bowel and bladder will function in the long run.
So by looking at those three factors, the ARM index can give you a sense of what that long-term continence might look like for that patient.
Exactly. It helps us set realistic expectations for the families, and it guides our long-term management strategies. For example, a higher score on the ARM index might mean that the patient is more likely to achieve fecal continence. It can give us a roadmap and some hope.
That's really helpful. It sounds like the ARM index, it gives both medical professionals and the families some really valuable information. Okay, so let's talk about that long-term care. What are the key areas that need to be monitored over time?
Well, urinary function is a big one. We have to keep a close eye out for potential complications like urinary tract infections, which tend to happen more often in these patients. And then there's bladder dysfunction, which can be a problem too. The nerves and muscles that control the bladder, they might not work as well as they should. Sometimes kids might need to learn how to do clean intermittent catheterization, or CIC, to help empty their bladder completely. It helps protect their kidneys too.
CIC, it's like giving their bodies a little extra help to make sure everything's working right. What about bowel management? What are some of the things you have to consider there?
Bowel management is crucial too. These patients, they might need laxatives or enemas to help them regulate their bowel movements. And sometimes we might recommend a procedure called an antegrade continence enema, or MACE. It involves creating a small opening in the abdomen so we can administer enemas directly into the colon, It's a more targeted and